Good afternoon. If I could ask all of you to stand for the invocation of pledge and ask Lori Lang to join us or lead us in the invocation.
Good afternoon. Today we give thanks for the opportunity to care for our community. We are ever mindful of this great responsibility to provide healing and hope to those we serve. We ask that our efforts be guided by wisdom, compassion, and understanding. We join the hospital board in seeking this insight to make decisions that will lead to a better and healthier community. May all that is done here today be for the good of those who have placed their trust in the Sarasota Memorial Healthcare System's leadership. Thank you.
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, everyone. I call this meeting of June 2019 to order. And before we get started, let me just read a public comment statement. Any citizen desiring to address the hospital board should turn the speaker card to the board secretary, sits over here. If the citizen's comment pertains to an item on the agenda today, the comment will be heard early in the meeting. Otherwise, it will be heard towards the end. Speakers are asked to limit their comments to 5 minutes. Vendors, suppliers, or other persons seeking hospital contracts awarded on a competitive basis are reminded that their ability to address the board may be restricted by the terms of the invitation for bid, requests for proposals, or other purchasing criteria. Lastly, the board has established a claims adjustment review panel comprised of representatives of the board, the medical staff, administration, and legal counsel to review and negotiate the settlements of claims. Accordingly, the board will not entertain comments on or discussions or negotiate claims at this meeting. Okay, thank you. All right, I'll take a motion to approve the orders of the day.
A second.
Any discussion? All those in favor signify by saying yes.
Yes.
Opposed, no. Thank you. Next, I'll ask for a motion to approve the minutes of the May 20th, 2019 board meeting.
So moved.
A second?
Second.
Any discussion, corrections, deletions? Hearing none, all those in favor of the motion signify by saying yes.
Yes.
Opposed, no. Okay. We don't have any board reports, so we'll move on to our continuing medical education portion. I'll ask Dr. Seaman to introduce our guest.
Thank you. It's with pleasure to introduce Dr. Lee, interventional radiologist who practices at our hospital. He's been on staff since 2013, did his medical school at George Washington University, internship at Beth Israel Deaconess, residency back at George Washington University, and did a fellowship also at Georgetown University Hospital. He's board certified in interventional radiology and diagnostic radiology, and is a leader in interventional radiology and brings cutting-edge techniques to our patients at the hospital.
Well, thank you, Joe. I didn't make it the last time. I have 3 little kids and I got sick, so I feel bad, but here I am, and nothing's really changed. So, it is interesting. I've been here for 6 years, so I'm going to talk a little bit about just what we've been doing, and I've actually talked about this procedure that we're going to go into here 3 times. This is the 3rd time, I guess. So this is maybe a little bit of an update. If you don't know what an interventional radiologist does, chances are you don't want to, because if you're seeing us, we're doing some things to you for diseases and conditions that you don't really want. But one of the subsets is interventional oncology, and that's actually where I focus most of my practice on. We do everything from diagnostic to therapeutic to palliative procedures. So that means we're doing most of the biopsies under image guidance to diagnose people with cancers. We've got a couple of things that we do to help oncologists treat, and then we've got some procedures of our own, which we'll talk about here, that I use to treat tumors. And then we palliate people, basically meaning towards the end, we help people feel better and give them a quality of life without having to do big surgeries. how we do this is that we do things with image guidance. So we don't have to make big incisions. We do everything through small holes, and we use the imaging that we have to make things accurate, to minimize the recovery, and to kind of make things individualized and patient-centered. So if we see a lesion in someone's lung that we're going to biopsy, like if Joe sends me a patient, well, we target it based upon the best pathway to get there and not having to cut the patient open. So this is a little bit of a timeline. So I did actually start here almost to the day 6 years ago in 2013. We treated our first patient with a procedure that I'm going to talk about called selective internal radiation therapy in September of that year. That was actually something that I had done when I was working on faculty at Georgetown and brought it down here. So it took a little while for us to grow, but we did grow. We went from 0 to 42 patients in 2 years, and that's a lot because the patients have to come in several times. We have to get the systems ready. We have to go through nuclear medicine and get them ready to do the procedure. We're now part of a multi-centered trial called the Resin Registry, which is a large national registry throughout the country. It's trying to collect a number of data points on all patients that are treated with this procedure. And we're actually one of the first sites to analyze patients with a new type of software so we know exactly what type of radiation dose that we're giving. This is the procedure. It's radioembolization or selective internal radiation therapy. What we're basically doing, to sum up this slide, is we're guiding a catheter to the arteries in the liver that are supplying the tumors. And we're injecting little 32 micron sized beads that are loaded with a radioactive isotope called yttrium-90 into the tumors. We're exploiting the fact that the tumors receive 100% or so, 99% of their blood flow from the artery. And so if we deliver a therapy via the artery, the beads are going to go where we want them to go in a selective manner. It requires us to have advanced imaging tools, little wires and catheters, and knowledge of the anatomy in order to make it successful. Since the time that we started here, there have been several large randomized trials that have shown that we can actually change survival in patients who have metastatic colorectal cancer to their liver, but also primary cancers of the liver. It's approved by Medicare for both of those, primary and secondary liver cancer. And from a standpoint of an organization, it's got a lot of things that make it good because you've got downstream things like nuclear medicine, imaging, surgery, et cetera, et cetera. And I'm going to show you one of those cases. This is what we're trying to do. So I borrowed this slide from one of the radiation oncologists who made it up, named Andy Kennedy. Essentially, external beam radiation comes from the outside of the body in, and so it's got to pass through normal structures in order to get there. What we're doing here is we're sugarcoating the tumor with millions of these little beads, and each little bead has its own little cloud of radiation that it emits. And so one bead by itself doesn't really do it. It's having thousands or millions of the beads surrounding a tumor, such as this cartoon that shows, and you get this crossfire effect of very localized radiation that actually doesn't come out of your body. The isotope actually only penetrates about 2 millimeters in tissue. So you're not irradiating everybody that's around you. Everything's very much focal on the inside. And the trick is just getting it there. So here's a patient that we treated a while ago. She's 62. She presented with a colon mass. We biopsied it, showed that it was colon cancer in her liver and in her primary site in her colon. She went and tried alternative therapy, but she had spread, so she finally started on standard chemotherapy. And at the time when we presented her our tumor board, we felt that the best shot for this young woman was to go full bore. And so we thought we'd do a liver-directed therapy at the same time that she started standard colorectal chemotherapy. And the reason for that was because besides the sites in her colon and her liver, she had no other disease anywhere else. And so if we could shrink down that tumor in her liver, she could go and have a surgery where she removes part of the liver plus the primary tumor in her colon and theoretically be disease-free. And so what you see in the top right-hand corner, that's her presenting PET scan that shows this big tumor. It's the bright, sort of ovoid-looking thing in her liver. If you look down in the bottom left, that's actually after we've done the therapy, and that's showing where our radiation beads concentrated themselves. And then the bottom right-hand picture is actually after she had surgery. And she's one of my favorite patients because I got a chance to take out her Metaport when she was all done. the time period here is about 4 to 5 years, but she had a great response. She went on to be resected. We actually had pathology that showed the beads implanted next to the tumor. And she was disease-free for it was actually over 2 years. At this point, this slide's kind of old. And she's essentially disease-free. Having presented with metastatic colorectal cancer, which when I was in medical school, you had about a 6-month survival on. And so this case actually, go back, this case is a good example of just across the whole system. So it involved radiology, it involved nuclear medicine, it involved surgery, medical oncology, and just about everybody to get someone really where we'd like them to be. This is another older case, and this sort of centers a little bit more on us. This lady had metastatic breast cancer to the liver, and she had actually been diagnosed 15 years prior, had gone through chemotherapy and a bunch of different things, and essentially 15 years later presented to her doctor with some belly pain and got a scan and had a bunch of liver tumors plus some disease up in her chest as well. And so typically that would have been kind of we're not really going to do much. We may try some salvage therapies on her, but medical oncologist said, I'm going to start her on chemotherapy. She has a good quality of life right now. She's got a good performance status, but I'm not really sure I'm going to be able to do too much for her liver lesions. What you can see on the scan on the left is a PET scan showing the disease in her chest, which is lighting up, and then a bunch of tumors within her liver. So she had, I'd say, 5 or 6 livers on the right side of her tumor and 1 in the left side of her liver. So that's not a patient who can get a surgery, because by removing part of her liver, you're going to leave disease on one side. So we did kind of a combination therapy for her. The picture up on the top left is showing the radiation treatment that we did. It's kind of globally going throughout her right lobe. The picture on the top right shows an MRI that just shows the fact that there are a bunch of tumors, those white dots, in the right side of her liver, but then there's also this white dot, and I don't think my pointer will work, but if you look way up towards what would be actually the right-hand side of that picture, there's another white dot that's in the left side of her liver. And so because there's only one lesion over there, instead of treating that entire lobe with radiation, we used microwave ablation, which is something I actually talked about here like three years ago or so. But that's where we put a little probe in and we ablate the tumor. And so that's what the picture on the bottom right is showing. That blue circle shows the area that we ablated. And essentially, okay, there you go. Well, I made it easy. There's the tumor in the left. And so this is her PET scan. Again, this was a couple years later, but look at her liver. There's no spots in her liver that are showing up. And you can actually tell reference point because the tumor that's up in her lung is still kind of there, sitting in her lymph node. That wasn't treated by us. But this is a patient who had essentially a complete response in her liver with a multimodality approach. And one would say, well, there's still disease in her chest. What have we done here? Well, the problem is that unchecked liver disease is really bad. You go into liver failure, you get high bilirubins, and it actually will impede your ability to give chemotherapy to a patient. So this is actually a big win. She's actually still alive today. So moving on to where we're going. So those are all things that we've done since we've been here, and it would be kind of boring if we hadn't changed the program. But really what's a big deal and why it's a good thing that we're going to get a PET scanner here and it's a good thing that we're doing this cancer center is we want to know if we can be more precise with the delivery of our treatments. And so these are just a few articles that show how using post-procedure PET scanning can enhance our ability to understand what tumors get what. Because I showed you a bunch of slam dunks here. It's not always like that. This is a paper that basically retrospectively reviewed the use of PET and MRI to understand where our beads have landed and where they're doing their most damage and where we want them to do their most damage so we can spare normal liver and have good outcomes. Basically what it shows in these slides here, and I'm just kind of sum it up, but it's not a uniform thing. It's not like we just say, okay, I'm going to give this tumor X amount of radiation and it uniformly happens. All those colorful little lines there show you patients who have either not responded, the red lines on the graph that's on the bottom, all the way towards the left of the graph, towards the y-axis. Those are patients who didn't respond. They didn't get the threshold of radiation that we wanted them to get, versus the people that responded are the ones in green, and they're a little bit more off to the right. They're away from the y-axis. So how do we figure that out? Well, we have to use software for that, and we actually became one of the first places in the country to do that. And just to let you all know, I gave a talk in Cairo about this, and I'll be going to Singapore, just to toot my own horn. I'll be going to Singapore to talk about it, and I bring the whole Sarasota Memorial, cancer logo on there. So We're international now, just in case you were wondering. So this is a patient that we just did recently. Essentially, here's one of the reasons why we don't get a total kill. Tumors don't behave. It's not just one blood vessel that supplies the tumor. So if you look at these two pictures, you'll see sort of this spot that looks fuzzy up at the top of the picture. That's two arteries that are supplying that tumor. So I have to be able to figure out how to get my catheter into both those arteries. If I miss one, then I'm going to get an incomplete response. So this lady, we figured that out. We treated selectively each one of those tumors. We targeted the tumor to 300 gray, which if we had a radiation oncologist here would tell you that's a lot of radiation. But we actually only treated 400 cc's of her liver, which is really like not even a third of her liver. And this is what the software looks like. We're actually trying to do what's called a radiation segmentectomy. A segmentectomy would be where a surgeon would go in and would cut out that part of the liver. Well, we're trying to get the exact same product by putting a concentrated dose of radiation into that spot. But how do I know whether or not I got enough radiation in there? Well, these pictures show us that we're allowed to, we can contour the liver, we can see the activity that we got, we can see how things distribute, and we did all these images here at SMH. And so, again, this is a slide that's got a lot of sciencey stuff on it, but if you look at the top, we can see the top left that the number way up there is 263 gray. That is tumoricidal. That means that is going to kill that tumor. And then if you follow it all the way down, the purple line, which is the outer rim, shows that that's about a threshold of 55 gray. So anything beyond that, the liver is going to be totally fine. But anything within that sphere is going to be dead. And the proof is in the pictures here. I actually just saw this patient in follow-up last week. So the bottom left-hand picture is what she presented with, this big primary liver tumor, that's that kind of white area that looks geographic way up in the top part of the liver. And then if you look at the picture to the right of it, it shows it's just this burnout hole, just like a scar. So where's our SMH practice? This is what it looks like. I know this based on Medicare statistics a little bit, and I know that we're not catching everybody that we could, but we've done a pretty good job. We had a little lull in 2017, 2018, but I just basically put myself to getting it ramped up again. We've treated 35 patients so far this year, so we're on pace to exceed anything that we've done before. And I'm really hopeful that the Cancer Center is gonna push this even higher, because we've actually hired some additional help to make this program go even better. And that's it. Thank you very much.
Any questions for Doc? Well, thank you for your leadership.
Thank you.
All right. You need a board member to go to Singapore?
I'm only going to be there for like 36 hours, so
There you
it's
go.
kinda
No,
brutal.
thank
Unless
you.
you like flying, I wouldn't recommend.
Not often, Justin. So I do want to, while Greg's making his way up here, say something about Dr. Lee. He is, how long have you been here now? 6 years? Yeah. So he really came in and helped us. It was really catalyst for change for our interventional radiology department. The board recently approved the expansion of University, where we're adding a PET CT scanner and interventional radiology suites. That's where he's gonna. He's the one that's been at my front door, talking about that for how long? You been here? 6 years. 6 years. You did a great job.
Thanks, I appreciate it.
Good job. All right, I guess next up, Dave, is the Excel Award.
Yeah. So thank you, Mr. Chairman. I am pleased to get to introduce to you our Excel Award winner for June 2019, Ashlyn Wooten. Ashlyn, come on up. Why do you look scared? This was me. Come stand here. So all I'm going to do is say good things. I took all the other ones out, all right? Ashlyn Wooten is our June Excel Award winner. She's an equipment and project planner in our biomedical engineering and has worked at Sarasota Memorial since 2011. Her co-workers describe her as an integral part of their team and someone who is always on top of her game. Ashlyn listens well, forgets nothing, and has a precise eye for detail, one of her co-workers said. Another says she's a diligent worker who is consistently professional and polite, calm and unshakable. She follows up, follows through, and her projects always exceed expectations. Ashlyn always has a smile and is kind thoughts to share, her team says. She inspires everyone around her. She possesses a quiet strength we admire, and she's a real rising star. Ashlyn, thank you for everything that you do. We appreciate it. Hold on a second.
Our Excel Award. Excel recipients are employees who are models of excellence and consistently demonstrate the mission, vision, and values of our organization. They are superior performers that make an extra effort in the quality and care of our patients and families in the community. The Hospital Board and administrative staff of Sarasota Memorial Healthcare System recognizes you, Ashlyn, with the Excel Award for the month of June 2019. Thank you for your continued dedication to excellence. And it's signed by David Barron, our President and CEO, and Joe DiVirgilio, Chairman of the Board. Congratulations.
Thank you so much.
So, Ashlyn, would you like to say
Oh, thank you. I feel truly honored. I've been working at Sarasota Memorial now for 8 years, and I feel blessed just to work for such a great organization. It's an amazing place. Thank you.
Thank you. Congratulations. All right, next up, we have, I guess, a couple of motions as a result of the medical staff. And Dr. Seaman, I guess you're going to kick it off?
Yes, I have two motions from the Medical Executive Committee and the medical leadership at the hospital, and those will be presented by Ms. Sharon Wetzler de Peters. Thank you.
Yes, and we are seeking recommendation to approve hyperbaric medicine privileges. So I move approval of the hyperbaric medicine privileges as recommended by the Medical Executive Committee.
Second. We have a motion, a second. Any discussion? All those in favor signify by saying yes. Yes. Opposed, no. Excellent.
And I have the second motion, and it's a recommendation to approve pain medication privileges. So I move approval of the pain medicine privileges as recommended by the Medical Executive Committee.
We have a second. A second. Discussion. All those in favor signify by saying yes. Yes. Opposed, no. Okay, thank you, Sharon.
That concludes my motions.
Dr. Seaman, anything further?
That'll be all. Thank you.
Alrighty. Good. All right, we'll move on to the foundation report. Mason Ayers.
Thank you,
Welcome.
Mr. Chair. Don't have a lot to share today, other than just wanted everyone to know that we have started our planning process again for the 3rd annual hospital gala, which will be on January 11th at the Ritz. I hope all of you can attend. That concludes my report.
All right, thank you. Look forward to another great function. Appreciate it.
Yep.
All right, Secretaries Report. Greg Carter.
Thank you, Mr. Chairman. For this month, or next month, on Monday, July 15th, from 9 to 10:30 a.m. will be the Finance Committee. And from 10:30 till noon will be the Quality Committee. From noon till 12:30, we'll have the closed session of the Hospital Board meeting. And from 12:30 to 2 will be our board lunch and discuss issues and financial review. And from 2 o'clock till 4 p.m. will be our board meeting. And that concludes my report.
Thank you very much. Treasurer's Report. Sharon.
Yes, and I have a motion. I move approval of the bad debts and charity care for the month ended May 31st, 2019, in the amount of $21,895,000.
Ready. We have a motion. Second.
Second.
Any discussion? All those in favor signify by saying yes. Yes. Opposed, no. Okay. Sharon.
That concludes my report,
All right,
Mr. Chairman.
Thank you very much. All right, now that we've kicked off our Treasurer's Report, let's move on to financial highlights with our Chief Financial Officer, Bill Wilgin.
Thank you, Mr. Chairman. Good afternoon. I have the financial highlights for May, and we'll start with operating revenue for the system. And with May being the 8th month of our fiscal year, the fiscal year-to-date numbers represent 8 months of activity. So operating revenue for May, $89,761,000, compared to a budget of $71,949,000. Fiscal year-to-date, $655,443,000, compared to a budget of $603,257,000. The system's total expenses for May, $76,989,000, compared to a budget of $72,287,000. Through 8 months of our fiscal year, total expenses of $600,740,000 compared to a budget of $586,326,000. The system's operating income in the rating agency format for May, $16,776,000, which represented an operating margin of 17.7%, compared to a budget of $3,588,000, representing a budgeted operating margin of 4.7%. Through 8 months of our fiscal year, operating income of $86,999,000, which represents an operating margin of 12.5%. And this compares favorably to the budget of $48,335,000 with a budgeted operating margin of 7.5%. Moving to statistics for the hospital, and these are year-to-date numbers. Average daily occupancy through 8 months, 590 patients, compared to a budget of 564 patients. Our acute length of stay on average, 4.3 days compared to last year, which is 4.48 days. On admissions, we have 29,087 admissions through 8 months, compared to a budget of 25,427. Continuous statistics for the hospital, surgery cases through 8 months, 16,943, compared to a budget of 16,523. And so far this fiscal year, we've had 2,558 births, compared to a budget of 2,333. Outpatient registrations, again through 8 months, 321,959, compared to a budget of 327,965. And registrations in our 2 emergency care centers, 86,345, compared to a budget of 86,056. So far this fiscal year, our case mix index for all patients, 1.81, and for Medicare patients, 1.89. Mr. Chairman, that concludes my report unless there's any questions.
Any questions for Bill? All right, hearing none, we'll move on. Committee reports. Our Governance Effectiveness Committee, Greg Carter, Chair. Your report, please.
Thank you, Mr. Chairman. As previously announced in April of this year, Susan Tucker, who filled an at-large seat on the board, resigned pursuant to the board's right and responsibility to fill that seat. We advertised the open position and asked for volunteers to submit applications to serve. I am happy to report that we had a dozen well-qualified applicants for this position. At a specially set Board Governance Effectiveness Committee meeting held on June 6th of this year, the Governance Effectiveness Committee carefully reviewed these applications and selected 3 of the applicants for interview. This morning, we interviewed those 3 applicants, and I'm pleased to report that we selected Britt Reiner to serve as a temporary member of the board until the next general election. At this time, I move to appoint Britt Reiner to full at-large seat 3 pursuant to Section 1, subparagraph 4 of the Sarasota County Public Hospital District Charter.
I second that motion.
Any discussion? All of those in favor signify by saying yes.
Yes.
Opposed? No? All right.
I want to thank all those community members who did express an interest in serving, and at this time, I'd like to welcome Ms. Reiner to the board.
Hey.
Ms. Reiner will actually join the board meeting once she takes the oath of office. And I guess the governor's got to bless that. So we'll get the administrivia out of the way, and we look forward to seeing you next month.
Did you just make up a word, administrivia? Because if you did, I'd love it.
When you grew up in my previous life in the utility world, administrivia was continuous with dealing with the state regulators. So anyway,
Mr. Chairman, maybe it'd be appropriate if Ms. Reiner would say a few words. I'd love to
See?
hear from you.
Control it. If you just want to take the mic, and if you would like, sorry to put you on the, but
Oh, she did.
you can get even. You can get even with Mr. Hudson when you join the board.
A public servant answers the call. Thank you for your confidence in me to join you on this board. I was really delighted to see the congeniality and teamwork that you displayed even in the interview process today. And I'm so excited to get to serve this hospital in my capacity today. As I mentioned to all of you, I was born in this hospital, I volunteered in this hospital, I interned in this hospital in college, I've given birth in this hospital, and now I'm very excited to come back and apply my business skills and civic leadership to this board. I'm very hopeful and confident that we will continue to make this healthcare system the best place for patients to receive care, the best place for people to work, and the best place for doctors to practice medicine.
All right.
Thank you.
Hey, Brett.
Welcome. Welcome.
I can tell she should have been a home run.
And get that speech down for when you are running in November of next year. There you go. Well, anyway, congratulations. We look forward to working with you. All right, we'll move on to the Human Resources Committee, and Bill Noonan, Chair.
Okay, thank you, Mr. Chair. Lori Bennett, Executive Director of HR, gave an HR update this morning to the HR Committee. Ms. Bennett began the presentation by reviewing an environmental scan which portrayed the hospital system's rapid growth over the last 6 years. The scan also included a look at Florida's economic history, current status, and trends. Next, Ms. Bennett discussed the demand for talent and supply of labor. She then went over the challenges of hiring and retaining employees given the rapid growth of the hospital system and a low regional and national unemployment rate. The hospital system is forecasting a significant increase of employees over the next 3 years with specific demands for the Cancer Institute, the Venice Hospital, and First Physicians Group. Then Ms. Bennett shared that the system's overall and first-year turnover has consistently improved year over year. HR will continue to focus efforts on retention, specifically by identifying the right talent and giving proper orientation to new employees. Finally, Ms. Bennett described the proposed timelines for hiring and onboarding new employees, managers for the Cancer Institute and Venice Hospital. That concludes my report.
All righty. Any questions? Well, thank you very much.
Thank you.
Next up is the President's Report. Give David a minute to kind of stroll down to the mic. David Varinger, our President and CEO. David?
Thank you, Mr. Chair. So I am start off like I do every month and talk about our organizational report card. This is the data on here is our fiscal year to date through May of 2019. The first category we look at is our area of service, and our goal in that is to have our system patient experience, or our likelihood of recommending of the number of services at 8 out of 10 and greater than or equal to the 75th percentile. I'm happy to report that we are exceeding that at this point and hitting 9 out of 10, and I'll show you the details on that in a minute.
Outstanding.
In the people section, as we looked at this morning in the HR committee, our goal is to have our turnover of our part-time and full-time employees that have been hired within the last 12 months to be 24% or lower. I'm happy to report, as we discussed in HR committee this morning, that number is coming in at 21.87%. So once again, probably the lowest in our modern day history. So thank you, Lori Bennett and Lori Lang, for all your work on that. In the quality section, we have our infection prevention. Our goal is to have our combined overall standardized infection rate at 0.93 or less. Just to remind everyone that the expected number or the national average is 1.0. We are doing really well in that at 0.67, quite a bit better than anyone else is doing. So congrats to all of our staff in helping make that happen. In the finance category, we have our goal of having our operating margin at or greater than 6.5%. As our CFO, Bill Wojcik, reported just a minute ago, we are projecting to exceed that right now at 10% operating margin, so doing very well there. And then finally, the last category we look at is in growth. our strategic growth organization goals. The first one is our inpatient admissions combined with our outpatient observations. We have a goal of having 46,000 for the year. We are tracking higher than that at this point at 50,328. And our secondary goal in growth is outpatient registrations. We have a goal of being just under 900,000 for the year. Happy to report we actually have climbed above that and are tracking it at just over 900,000. So I'd say we have a pretty good looking report card right now. When we look at our patient experience detail, we look at the 10 different areas that we look at our likelihood of recommending that you can see there on the left-hand side. The first number you see is what our actual score is. The second number, which is in green, is the national median score. And then the third to the right is the 75th percentile score. So you can see that we're hitting everything in the national median. We're at or greater than. And in the 75th percentile, we are actually hitting in 9 out of our 10 areas. The one that's a little bit short is our emergency care center on the main campus. But it is moved above the national experience number now. So very, very happy with these results, and I think that it really shows what's going on throughout the organization. Moving on, we're going to look at Venice, our Venice operation. On June 11th, the Venice City Council unanimously approved a zoning amendment that allows a hospital and healthcare facilities to be constructed on our site. The city's planning commission had previously approved SMH's site and development plan, and a new full-service hospital is on track to open in 2021 with 110 private patient suites and plenty of room to grow for the community. Sharon Roush is our president of our Venice operation, as you all know. Sharon, thank you for getting this over the line. We very much appreciate it. Looking at some other issues, we had a new drug, stops dangerous bleeding linked to blood thinners. So Sarasota Memorial is among a handful of hospitals with the first and only antidote to stop life-threatening and uncontrolled bleeding linked to newer blood thinner medications. As a clinical trial site for andexanet, a new drug that can reverse the factor XA inhibitors blood thinning effect, Sarasota Memorial was able to offer the patients early access to the drug. Dr. Mauricio Concha, who's pictured there and is our medical director of our Comprehensive Stroke Center, participated in a national study with SMH and Intercoastal Research Center team. He co-authored and final results published in the New England Journal of Medicine and presented findings to the International Stroke Conference in February 2019. So if you see Dr. Concha, please thank him for all his work in representing us and our patients. Earlier this month, Sarasota Memorial partnered with local law enforcement to conduct a Code Green or mass casualty training exercise to test the hospital's response to a sudden influx of patients. A group of specialty trained SMH staff known as our Hospital Emergency Access Team sprang into action during the drill to set up a decontamination zone on the first floor of the garage, and it's the south garage that we convert into that. SMH regularly holds disaster drills as part of its comprehensive emergency management program, and it's just something that we do regularly to make sure that we have everything in place and ready to go, whether it's a hurricane or whether it's a chemical spill or anything else that can go on. And we appreciate our response team being there. Speaking of that, it's time for medically dependent residents to register with Sarasota County. Hurricane season runs June 1st through November 30th, which means now is the time to make sure your home, your family, and pets will be safe in a tropical storm or hurricane. SMH is a designated medical shelter for patients as well as medically dependent Sarasota County residents who require a hospital setting during emergency situations and who are assigned to the hospital by Sarasota County. Community members can complete the medically dependent person form and learn more about the program at Sarasota County's website. And I would just emphasize that you not wait until a storm comes before you do this because everything starts to get a little bit more chaotic around that, and it's good to know where our patients and community members are going to be going. We also, earlier this month, our Sarasota Memorial held its annual service anniversary celebration, honoring the dedication and contributions of hundreds of employees, marking 5 to 45 years of service with the organization. At right is Judy Wilson of pre-admission testing, who was the longest-serving employee at this year's event, celebrating an incredible 45 years with SMH. So thank you to everyone who was recognized and honored that night. So in 2017, I know you're about to think that I have Greg Carter here walking a tightrope, but that's not really what the story is. In 2017, SMH's trauma team treated several of the Walinda performers, including Nick's sister, who were injured in a fall. Now the Walindas are gearing up for one of the biggest performances of their lives, walking a high wire above New York City's Times Square on June 23rd. Sarasota Public Hospital Board member Greg Carter and his wife Carol stopped by the duo's practice recently to watch the action and take a few photos. So, Greg, did that go well?
It went very well.
Good. Thank you for doing that. Just to touch on, SMH Employee Campaign is an epic success. Many thanks to our employee partners in caring who generously contributed to the recent epic campaign. During this year's campaign, more than $138,000 was raised by 650 donors, resulting in a 22% increase in funds and an 11% increase in donors. To date, employee support of the EPIC campaign has raised more than $1 million for staff education, equipment, facilities, technology upgrades. So thank both our staff who lead that here, also Mason, the foundation staff, for really keeping us on track and making sure that goes smooth. So appreciate that.
You're welcome, David.
Wanted to talk about a new family practice that is opening in Venice. First Physician Group continues to expand access to care with Dr. Megan Bueller moving into the new family practice on Commercial Court in Venice. Dr. Christopher Jensen will be joining the practice this coming September, and I believe we have a lot more room to grow there. Dr. Bueller's been practicing on our Venice Bypass property and is moving her practice over, so continuing growing in that area. Another one that we have coming up is our Lorraine Corners Medical Office building, which is scheduled to open in mid-July. Excuse me. First Physicians Group will open this spacious new medical office building at Lorraine Corners off of State Road 70 and Lorraine Road. The nearly 13,000 square foot facility will open in mid-July with 3 internal medicine physicians and 4 pediatricians. It is built to where it can actually house a 4th internal medicine physician as soon as our volume dictates that. Also can house multiple specialists going through there in timeshare units. So if you haven't had a chance to go in that part of our service area, I'd encourage you to take a drive by that and take a look. It's a beautiful building. And with that said, that is my report. I'd be glad to answer any questions.
Any questions for David? David, I just have one comment, and
Please.
you reinforced it, but about 3 years ago, we challenged the staff at the hospital and the nursing staff to reduce the infection rate. We were dragging a little bit above the national average, and I got to tell you, just please pass along. It takes a lot of work, but to get it down to that .67 number is phenomenal. So well done to everybody.
Thank you, Joe. I definitely will. Connie will certainly pass that
Yes,
along
definitely,
too.
Connie. I mean, we challenged you,
and Dr.
and everybody
Fiorica.
said we got to do something, but quite honestly, like this hospital does and everything else, you guys have gone well above and beyond, and obviously it has major impact on our patients, so thank you.
It's the staff that does it, but I will pass along your comments. Thank you.
Appreciate it. All right, Karen, we have any public comments?
No, sir.
No. Any legal matters?
No reports.
No reports. Any other business? No, if not, we stand adjourned. Thank you, everyone.